Klane White. It's a privilege for me to be here this afternoon again and introduce a wonderful orthopedic surgeon. Klane White is the chair of the Department of Pediatric Orthopedics and the Rose Brown Endowed Chair of Pediatric Orthopedic Surgery at Children's Hospital in Colorado. He is a professor of orthopedics and vice chair in the Department of Orthopedics at the University of Colorado School of Medicine, where he is also professor of genetics and metabolism in the Department of Pediatrics. Dr. White is an internationally recognized expert and advocate in the care of MPS and skeletal dysplasias. He is the principal investigator for multiple international research studies on emerging treatments and rare diseases. Dr. White is the executive founding member and current president of the Skeletal Dysplasia Management Consortium. In addition to skeletal dysplasia and MPS, in addition to the skeletal dysplasia and MPS, Dr. White's clinical and research interests also include the diagnosis and management of early onset scoliosis, metabolic bone diseases, and complex spine deformities. Dr. White has authored more than 100 peer-reviewed publication review articles and book chapters and serves as a standing reviewer for both orthopedic and rare disease journals, and we are honored to have him on our scientific advisory board. Thank you, Dr. White.
You shorten that bio. Got to figure out a way to shorten that bio a little bit for her. Anyway, way too much about me. No, thank you. And I realize this is the 40th meeting, so this is really a landmark year. So welcome to everyone here, and it's fantastic. Such a great turnout. The run this morning, huge turnout, very exciting. Raising money for the MPS Society. Before I start, because I entered this world in 1999, and I don't have a slide on it this year, so I just thought I'd put it out there now, is that my daughter, Susanna, was diagnosed with MPS 1. And so Dr. Orchard was one of her doctors, and I got to know Dr. Munzer over many years as well. So I learned a ton from them. Unfortunately, Susanna didn't make it past age 9. She had some late complications related to some blood disorder stuff. But anyway, so I come at this from a parent perspective, and so hopefully this comes across to you in a way that is meaningful and helpful. So we'll go from there. Just disclosures, this is just a lot of the research trials that I'm involved with, largely at this point with achondroplasia, but I was involved with the Morchio trials as well when Vimizim was being investigated. So dysostosis multiplex, this is the generic term that radiologists use for bone disease and MPS. And it means multiple bad bones, literally. And so this is the diffuse skeletal disease that really glycosaminoglycan or mucopolysaccharide mediated inflammatory disease of the bone. In children, this results in a progressive deformity. So this can be hip disease, spine disease, your knees, your ankles, your hands, whatever. Later, as we become adults, then it becomes more of also a joint disease, so arthritis primarily of the hips and the knees. So I'll talk a little bit about all of this today. So a little bit of background here. So how do bones grow? Well, we have these growth plates at the end of the bones, and we have these cartilaginous plates. And from there, you have growth of cartilage, which then turns into bone at the ends of the growth plate. And our bones grow from the ends, away from the center, towards the ends. Now, in MPS, you get this accumulation of these glycosaminoglycans, which results in a very disorganized column of cartilage, and then disorganized bone growth at the end. So that's why these bones grow differently. And this is both mechanical and biological. So before we talk about orthopedic surgery, I think for any intervention in medicine, we always have to think about, will this intervention improve my function? Will it decrease my pain? And most importantly, will it improve my quality of life? And the quality of life is a checklist of many different things, and it's very different for different people. So when we talk about interventions, it might mean something different to one person than it does to another. We all have different values in the way we think about life and how we want to proceed. So before we talk about surgery, we talk about alternatives to surgery so that we can try and optimize quality of life without doing a large surgical intervention. So when we're talking about bones and joints and the musculoskeletal system, Obviously, weight loss and weight maintenance is really important. We're putting less stress on our joints. This is easier said than done. I don't know about MPS, but now with GLP-1s and other kind of things, we maybe have some better ways to control this. Assistive devices, scooters, canes, etc., can really change someone's life. I can't always make someone walk better, but if I can get them a scooter, I can make them extremely independent. Orthotics, braces, shoes, pain-relieving medications can be helpful as well. So alternatively, when do we operate? Okay, well, when that pain and deformity limits everyday activities, or if there's pain at rest, day and night, or if when we're talking about the spine, or maybe carpal tunnel syndrome, we're looking at, are there neurologic deficits? So these are changes that if we don't intervene will become irreversible. Or sometimes we think we know that this is just going to be bad and we'll intervene, but that's a little bit vague, and so I try to avoid that. Don't memorize this. This is just basically showing you that there are a lot of orthopedic problems we see in every single form of MPS. And so you're welcome to study this at some other point if you'd rather, but I'm not going to dwell on it. So I'm basically going to work from the head down to the toes and orthopedic aspects, and start with probably what is the most, the scariest and most impactful problem we see in skeletal dysplasia and MPS, and that's abnormalities of the cervical spine. And so why is this important? Because if you have cervical instability, you can end up paralyzed, and then obviously that's a high risk for morbidity, even death. And so we are fairly aggressive about surgery when we see problems here. So let's see. So what do we see in the cervical spine? So this cervical spine is up in the neck, right? So this is what we see is delayed ossification, or smaller bones that make a smaller canal for the spinal cord. So the spinal cord would be this yellow line going through the middle and going through the rings in the spinal canal. So we talk about C1 ring hypoplasia. So that's let's see if I can go back up here. So that's the upper bone. It sits on C2, which is the lower bone here. And so when there's ligamentous instability, particularly in Morquio syndrome, but we see this in all forms of MPS, then you get what's called C1, C2 instability, or atlantoaxial instability. And so this can result in spinal cord compression and secondarily injury to the spinal cord. So how do we surveil these? Well, we start with x-rays. We still, x-rays were developed now over 120 years ago. We still use them. They still are helpful for us in trying to understand things. We will do this in different positions to see if the bones move on each other, as I showed in that video. Sometimes we'll use a CT scan or computerized tomography. MRI at this point is the best way to look at soft tissue. So x-rays and CT are really good at looking at bone. MRI is good at looking at soft tissue, so ligaments and neural elements. And then if we're really not sure what's going on, we can get what's called a flexion extension MRI. Again, that's a dynamic test. We're looking at whether the spinal cord is being pinched with different positions of the neck. And then if you're having surgery, sometimes we'll check the blood vessels, which can be really abnormal in patients with MPS. And if you don't know where those blood vessels are, you can get into trouble if you're in surgery. So this is what that x-ray looks like. If you kind of look at these two lines, they're lining up on the left side, and when the person flexes their head forward, the position of the bones changes substantially. And so if you see where that little star is, that's the space, what we call a space available for the cord. That's the area behind or within the canal, in front of the posterior arch, but behind the body of the vertebral body. And so the less room there is there, then there's less room for the spinal cord, and that you're a higher risk for having a spinal cord injury. Here's just what we see on CT and MRI. So again, you can, on the left, that's a CT scan. You get great visualization of the bone. On the right, you can see all the soft tissues. You see the bottom of the brain. But what's really important here is what we see is that bone is moved forward on the CT scan, and that little blush of signal change on the MRI means that spinal cord has already been injured. So how do we know if someone's starting to develop symptoms or problems with cervical instability, or sometimes it's just narrowing, what we call spinal stenosis? Well, they develop a term called myelopathy. So this is weakness, clumsiness, unsteadiness of gait, and if it's really late, bowel or bladder control issues. People who are unstable but haven't had neurologic injury, so they haven't developed myelopathy. They might have neck pain or headaches because the muscles are working extra hard to hold the bones in place. When do we operate? Well, we don't have any total, clear, concise answers, but generally speaking, if you see changes like myelopathy, so neurologic changes, that might be changes in reflexes. So if you go to the spine surgeon's office, they'll be checking your knees and reflexes. If you see obvious instability, so that's probably at least 5 millimeters of instability, or if we see that MRI evidence that the cord has already been injured, as I've just showed you. So those are, to me, absolute reasons to intervene. So what's the surgery? So what we do is we take off a piece of bone in the back at C1. So we take that bone off, relieves the spinal cord there. And then, but in order to stabilize it, we have to put hardware in. So we put these plates and screws, and then we put some bone graft in. So this is what we call an instrumentation and fusion. The bone graft is the fusion. Think about rebar, concrete and rebar, and that holds that straight. I had one family who was really concerned about the motion of the neck afterwards, but you can see you still have a reasonable amount of motion afterwards, and it's much better than being paralyzed, I'll tell you that. So this is just a patient with MPS II. It looks, you can see it on the left. There's the C1 has come forward quite a bit. The animation didn't hold up here, but then had this surgery to stabilize. So that's what it looks like on X-ray. And this is a Morchio patient. Again, you can see that significant instability. You can see the pinching of the spinal cord at the top there, just below the brain. And this patient had a similar surgery, but this time, because sometimes the bones are just too small to get instrumentation in the spine bones, we have to go up to the skull to stabilize things. So we call that an occipital cervical fusion. Moving down a little bit, this is where at the cervical thoracic junction. So if we think about the spine, there's a cervical spine, the thoracic spine, which is where the ribs are attached, and the lumbar spine, which is the low back. So at the junctions of these segments is where the most mobility is and where we tend to see a lot of the problems. So again, at the base of the skull as well, and then at the cervical thoracic junction and the thoracolumbar junction. This is, I think, a highly underappreciated area of the spine, and most people don't bother to really look. But it's, it is spinal cord level and can cause problems with the spinal cord. And I think this is where we get into trouble as surgeons when we might be doing hip surgery. So this is a patient of mine. This is from 2009. You can see it has this, I don't know if I can show it here, but you can see there's a little bit of kyphosis there. The spinal cord is draping over. I did this hip surgery. I was very proud. I thought this is a beautiful hip surgery. And then unfortunately, you can see on the right, you see now there's cord signal change in that spinal cord. This patient was paralyzed and will never walk again. And so and I'll talk about this later, but so when we're doing lower extremity surgery in MPS, we need to make sure that we are monitoring the spine because they can have problems like this that are underappreciated. Let's see, oops, sorry, it went. So thoracolumbar, moving down the spine, thoracolumbar kyphosis. This is really the pathognomonic or the quintessential deformity of MPS, particularly MPS 1. And again, it's at that next level junction between the thoracic and lumbar spine. And what you get is a forward bend in the spine. And so we call the outward deformity a gibbous, but when we're talking about the spinal deformity itself, we call it kyphosis. Okay, again, forward bend in the spine. So we too sometimes brace, but bracing isn't really treated. It won't make it go away. It might delay progression and might help us maybe avoid surgery, but it certainly won't cure it. We know from data from the Manchester group that deformities more than 45 degrees tend to progress, but if they're less than 45 degrees, we can watch them and probably never have to do anything. And I've seen a lot of kids come in with 35, 40-degree curves, and their surgeons are recommending surgery, and I'm like, yeah, no, we don't think we need to do that because you're going to be fine just without. Sometimes you'll see neurologic compromise, but that's extremely rare. So the surgery we do for kyphosis is a little bit, it's similar, it's still spine surgery. Here we're doing what's called we do posterior osteotomies where we release the back and then we can straighten the spine. Sometimes we'll put a fusion in the front, or sometimes we'll even go from the back and take the whole vertebral body out and put in what's called a cage. And what that allows us to do is get the spine straight. if you don't get the spine fully aligned and you just try and do a partial job where you just fuse the back and don't get them fully corrected, then there's a good chance that surgery is going to fail. And so achieving stability is critical. And then because the bones are small, I'll usually brace the patients for about 3 months afterwards. So this is just an example of an anterior and posterior fusion. Here you can see the instrumentation in the back. You can see the bodies are fused in the front here. Hopefully you can appreciate that. And the spine is nice and straight between. So this is kind of what the surgery looks like. We take those pieces of bone out of the back, we osteotomize it, take that out, we straighten the spine, put the rods in, and again, do a fusion. So we do osteotomy, instrumentation, fusion, and that's how we get these straight and corrected. And this is just what that looks like on x-ray. A little hard to see on this x-ray, but this was a 67-degree curve. You can see it doesn't really correct on the MRI. But what's really important to know about these MRIs is that the spinal cord actually ends just above the deformity. And so for most MPS patients, we're at the levels of the nerve roots, and so that's why we don't have to be really aggressive about these early on, because the spinal cord is much more sensitive to that kyphotic deformity than nerve roots, and nerve roots can swim around and be okay. So that's why I'll let these go, and so people look at me, I'm like, oh, I can go above 60 degrees and no problem, and everyone else is really nervous about it, and I'm like, it's fine, and I can let them grow as long as possible, because once we do this fusion, that part that's now instrumented won't grow anymore. So if you fuse a 5-year-old, that part of their spine is stuck at a 5-year-old spine's growth, okay? So we try to avoid that, but if we have to, we have to. Scoliosis is much less common in MPS, but scoliosis is probably something we're all more familiar with. This is the S-shaped curve of the spine. This is a Morchio patient who had it. And the difference between scoliosis, when we think about it as surgeons, is that in scoliosis, you're getting a compression of the chest wall, because it's not just a curve, it's a twist. And so if you try to turn like this and try and take a deep breath, then you'll feel like what a scoliosis patient feels like when they breathe. And so we worry about pulmonary compromise, whereas in kyphosis, we're always worried about that stress on the neural elements, particularly the spinal cord. And so we have different reasons for needing to intervene. Scoliosis in MPS is probably treated very similarly than it is to any other patient. So there's no special indications for MPS as opposed to anyone else with scoliosis. We can cast and brace them, that probably doesn't cure it, but it might hold it off. Again, we don't want to do a fusion like this until we have to. Growing rods are an option. I will say I've never done growing rods in an MPS child. I just don't feel... scoliosis just isn't very common in MPS, and it doesn't really help in kyphosis. So I know some Europeans have talked about it. It just doesn't make sense to me. And so, the complications are, sort of because these patients tend to be small, related around implants, and of course some pulmonary issues. This is an older boy who has Morchio, more attenuated form of Morchio. It's a little tough to appreciate, but he's got a little bit of a kyphosis here, but then he kind of developed this scoliosis around the kyphosis. So I had to treat both of those. And so here you can see we did a fusion, instrumentation, and got his kyphosis flattened out. And so again, just more x-ray how we do this. So hip deformities. So this is hip deformities in MPS. It probably should be using the term hip disease in MPS, because it's not just deformity, it's also, as I mentioned earlier, the cartilaginous disease, the arthritis. And on top of that, we get what's called, it looks like osteonecrosis, which is basically osteonecrosis means bone death, okay? So, and it mimics a condition that's called Perthes disease, where kids who have no other health problems, the blood supply to their hip gets compromised for a short while, and then you get these changes to the hip, to the proximal femur, but over time it reconstitutes and fixes itself for the most part. In MPS, you have this osteonecrosis-like look that doesn't do that. It just, the biology doesn't change, and it's forever looking like that. And that's really one of the major reasons why patients get arthritis, in addition to the cartilage that covers the ends of the bones anyway. So this is different. So we call this epiphyseal dysplasia. And then the deformity part is the subluxation and dislocation, where you have an underdeveloped cup, so that's the acetabulum, and you have a deformity to the femoral neck, and I'll show you what that means. But this tends, once you see it, once you start seeing that hip slipping out of socket, so that's the subluxation hip dislocation, then we know that they're going to end up with an arthritic hip. So it's a combination of issues here. It's the epiphyseal dysplasia and then the hip subluxation dislocation. So just so you know what normal hips look like, this is normal child hips on the left. You can see nice round sockets, those nice round femoral heads in the socket. And this is an MPS 1 patient. This is a 3-year-old with MPS 1. You can already see flattening of the femoral heads. You can see that those femoral heads are already subluxating out of socket. And here's that same X-ray. So we see what's called a break in Shenton's line. So that femoral neck should line up with that dotted line, not sitting up high like it is. You see how it's called coxa-valga. So this is a higher neck shaft angle, and then we have an underdeveloped acetabulum. So that combination of factors results in the subluxation of the femur. So these hips are starting to go out of socket. So we have ways surgically to contain this. And so for me, for a patient to need surgery, I need to see that those hips are starting to pop out of socket. If they're not popping out of socket, we'll talk about hip replacement in a minute. You can either do 2 surgeries, do a hip surgery when they're a child, a reconstruction for hips that are in socket and not coming out, and then do a hip replacement later because we know the biology is going to take over eventually. Or we just do 1 surgery, wait until they actually have pain. They can be young adults. We do hip surgeries in teenagers and people in their 20s quite comfortably these days. And so I'd rather just have 1 surgery when they're older than operate on hips that don't need to be operated on when they're younger. But when they do need surgery, when they are coming out of socket, we do what's called a pelvic osteotomy plus a femoral varus osteotomy. So we are correcting both the socket side and we are correcting the femur side. Now, there's different ways to do this. Now, if you go to Nemours, they'll do what's called a shelf acetabuloplasty. It's very similar. It's just 2 different words that kind of give you the same result. You basically want to get that femoral head in a covered environment to keep it from popping out of socket. And so this is just a video of what that surgery looks like. So this is the varus osteotomy. We cut the femur, we turn it in towards the socket, and then secure it with plate and screws. And then we go above and we cut the pelvis above, and then we bend that down so that deepens the socket. And so now we place a bone graft in there to hold it in place. And so if you look here, if you compare the left and the right hips, you can see this right hip is well contained within the hip. This left one is still kind of sitting out of the socket, okay? So that's what we're trying to accomplish with hip surgery in children. And this is just what that looks like on X-ray. This is a patient with MPS 4. Again, the San Diego osteotomy is a pelvic osteotomy. And then this is another Hurler. This is a Hurler patient who you can see the hips are becoming uncovered and not really sitting in socket. And then after surgery, they're much better oriented and better relationship. So we know, this is from our friends at the University of Minnesota. Dr. Orchard is not listed up there. He's an orthopedic surgeon now. So, but they were looking at hip surgeries, and this is a combination of pelvic osteotomies and femoral osteotomies, or sometimes just femoral osteotomies. And I think what they found was that radiographically, they made these hips look a lot better. But I think that, I can't remember I think it was about 9 years out. It was the average time out. But what they found was that of the 102 hips that they operated on, 5 of them developed osteoarthritis. So this is going to be usually by teenage years, right? 3 of them were the surgical group, and 2 were in the non-surgical group. So there's really no difference in. The point is, you don't prevent the arthritis necessarily. Now, you could say maybe if you hadn't done surgery, you'd have more non-operative, or you would have more operative, or yeah, you'd have more that had arthritis. But I think it just understand that the biology ends up taking over in the long run. And this is from the Irish group. And similarly, what they found was, they did these surgeries, and it's a little hard to read here, but Many of them had advanced arthritis, and after about 10 years. So it's not a panacea, and so that's why I've decided I'm only going to operate on the ones that I know are popping out of socket, because I'm not going to change that biology. See, so hip replacement. This is, we think about this as an adult surgery, and it pretty much is. But as I mentioned, we will operate on teenagers now with little concern, because if they're really that uncomfortable and doing that poorly, then this is a life-changing operation. Really, so the thing about MPS is that these, the patients tend to be low demand. So why do we worry about doing hip arthroplasty or hip replacement in young patients? Well, it's a mechanical device. Eventually, it will wear out. It's like a toaster or something, right? Eventually, it goes. And the problem is, you can't just buy a new one and plug it in. The analogy I use is, if you take your car in and get new tires, okay, then next time when those tires wear out, next time you have to replace the tires and the wheel, and then the next time it's the tires, the wheel, and the axle. It becomes more difficult every time, and the outcomes for a primary hip replacement, at least in sort of, if you just take your average adult, is the outcomes are like 95 to 99% fantastic. But if you look at revision hip replacement in adults, about 50% success rate is what you see. So, and if you think about someone who has more comorbidities, then that's even, so we want to make sure that we try and wait as long as possible to do a hip replacement. But at the same time, we don't want someone sitting around being miserable either. So we kind of find, and as I said earlier, everyone has their own threshold, and everything's a discussion. We want to make sure your quality of life is better. But when done, this can be a life-changing operation. So, and this is what what we do is then we take that arthritic hip, we remount the acetabulum, we put in this metal cup. It then has a plastic liner, and I'm sorry I didn't speed this one up like I did the other ones. And then what we'll do is we cut off the femoral head, and then we put a metal stem and implant into the femur, and this gives you a prosthetic hip. Got to speed this one up, sorry. So, and now, that you see that head there is a plastic head. Now we'll use all metal on plastic hips. We'll also use ceramic hips. There's many different hips that we can use for long-term outcomes. So moving down to the knees, we're talking about knock knees or genu valgum. This presents early and it's seen very commonly in MPS. If you think about knock knees, it's a little hard to walk when you're like this all the time. So it's not life-threatening, but it does change your quality of life and your mobility. So we have a fairly straightforward surgery for this. It's called guided growth. Some people have heard about 8 plates, but that's like saying Kleenex instead of tissue paper. 8 plates is a brand name. So, and so we can treat this. It's a relatively low-risk surgery. We do it through really small incisions. It takes less than an hour to do both legs if we need to. The problem thing, though, is if you do it at a younger age, sometimes you have to come back and do it again, so what we call rebound disease. So this is what it looks like. We see this knees, the yellow lines are what we call the mechanical axis, so those knees are coming in from those lines, and then once we correct it, you can see those knees are now coming outside of those lines. I actually over-corrected this one on purpose with the thought that, and I don't have a follow-up, but these knees will come back together because I'm expecting some of that rebound. And so this is what it looks like. And that's why they call it an 8 plate. It looks like an 8. But it's about the size of a paperclip. And what we do is we put it on the inside of the knees so that the outside of the knees will grow. And then with time, they will grow straight. You understand, once you put those plates in, you usually have to take them out. So it's never just one surgery. It's at least 2, if not more, if they get rebound. And then carpal tunnel syndrome. This is really common. We see it primarily in MPS 1, MPS 2, and MPS 6. And so we do test our MPS 3 patients for it, but I haven't really seen it. So I don't know you have to worry about it in MPS 3. But the carpal canal is basically it's a tunnel through which the median nerve, that's the nerve that goes to the hand and innervates your sensory on this part of the hand, but also the muscles that control your thumb and your ability to do this and pinch. Okay, so what happens is you get an accumulation of the GAGs, the glycosaminoglycans, and you can kind of make it out here. There's this where to go? Is this big accumulation here? And if you look closely, here's a nerve right here, and then it kind of gets out. See, it's pinched there. There's an hourglass of the nerve. It's been compressed, and so that's what carpal tunnel syndrome is: a compression of the median nerve. And so this will reduce sensation and strength in the hand. It is often asymptomatic. I would say almost always asymptomatic. But the children will maybe they'll rub their hands, they'll gnaw at their hands. It's hard to know, but if your child is younger or developmentally not able to express that they're having symptoms, then you need to test them. And so what we do is we do nerve conduction studies for this. And so it's just, you can do the sensory testing just with non-invasive electrodes. Most of the docs who will do this testing, though, they also want to do an EMG, which you have to put a needle in the muscle. So oftentimes we'll do this under anesthesia. But if you're just doing the sensory ones, it's not pleasant, but you can do it without anesthesia. Once the child is old enough to tell you whether they're getting numbness and tingling in their hands or they're getting weakness in their hands, then we kind of stop doing this. But but it does. I think it's something that needs to be checked every year or a couple of years, especially in young children, because it's extremely common, and the implications of this are irreversible, and so you want to get to it early. And so we say whenever there is any sign of nerve injury, even if it's mild, we don't wait. We just go. Okay, get it taken care of. Sometimes you'll also have trigger digits. This seems to be mostly in MPS 1, but where you get accumulation of the glycosaminoglycans in the tendons, and then they get caught, and so they'll pop and catch when the kids try and open and close their hands. And so we can take care of that at the same time as we do the carpal tunnel syndrome. And I always get asked about tarsal tunnel syndrome, so I put it in here. I think it's unclear whether this happens or not. If it does, it's reported as foot pain or tingling because it's again, this is a compression neuropathy. Nerve conduction studies are not really great for testing this, and maybe that's just because maybe it's not there, I don't know. But I think what's really important to realize, though, is that if you're having numbness, tingling in your legs or your feet, you got to make sure it's not your spine first, because that's going to be a critical issue. There's only one paper on this. They had 19 MPS patients, 4 who had suspected tarsal tunnel, 3 had decompression, 2 with good results, one of which had a complication, and then they had 1 patient who actually had spinal issues that masqueraded as a tarsal tunnel syndrome. So yes, it can happen. It probably can happen. It's not something I routinely check for. It doesn't have the same implications as carpal tunnel syndrome in terms of function, but especially if you have an older child, a young adult, who can tell you what's going on, and they have symptoms, then it's probably worth getting checked out. I'm just going to finish up with, because I'm a surgeon, and I have to always remind my orthopedic surgeon colleagues that there is actually a patient around all of these bones. And when they go to the operating room, they can get into a lot of trouble, okay? And so before you let your surgeon take you or your child to surgery, make sure that you have a thorough preoperative pulmonary, cardiac, and ENT evaluation. I will say, sadly, in my institution in the last year, we've had a death from sedation. And we had a near miss even about 3 months ago. So even in an institution where supposedly we know all about this, and we check for everything, we do everything, and I can tell you we have an excellent metabolic genetics team, it still happens. And so it's up to you as family members and friends to make sure that your loved ones get appropriate counseling before they go to surgery. You need to have a skilled airway person, someone who knows how to do video laryngoscopy and or endoscopic intubations. So, and I think if you go to any major children's hospital, that's not going to be a problem, but it's just, outpatient surgery in MPS is probably a no-no. Okay, and I know we've heard stories for many years about patients who go in, they get an eye surgery, and then, bad things happen. So just keep that in mind. And then neuromonitoring, and I'm going to come back to this point because I don't think it can be made enough. And so I didn't put all the publications on here, but now we have multiple publications on there, and I know there's some Cincinnati people here. They published on this as well. And so if you or your loved one is going to be having lower extremity surgery, I would avoid epidural anesthesia because then you can't monitor what's happening to the spinal cord because you're numb and you're weak because of the epidural, and it might be because you're actually paralyzed, and we don't know, we can't tell the difference. So we call it the program, it's Spine at Risk, and so this is neuromonitoring for all surgical procedures that last for more than 60 minutes. You need to have and you can see here we just set it up, and it actually takes about 10 to 15 minutes to do. It doesn't take very long at all, and it will save a lot of problems down the road. So key learning points: spinal cord compression is common in all forms of MPS and requires regular evaluation and surveillance, and is probably the most significant contributor to morbidity, if not recognized. Hip dysplasia should be treated when subluxation is present. Epiphyseal dysplasia, so that's the osteonecrosis, the biological changes, it still develops regardless, and so can be treated with joint replacement later in life. Knock knees or genu valgum develops early in childhood. Responsive to guided growth, slight overcorrection is recommended. Glycosaminoglycan accumulation does cause peripheral neuropathy, and so for young children or developmentally delayed children, nerve conduction studies on a regular basis are recommended. Diligent preoperative evaluation for cardiac and airway difficulties is imperative, and spinal cord monitoring for all patients who are having any surgery that lasts more than an hour. So, thank you.